So I think a recurring theme today has really been about how our California and local HIV epidemic is becoming increasingly concentrated in individuals and communities facing a lot of adversity, housing, economic insecurity, trauma, stigma, mental illness, substance use, racism, amongst other issues. At the same time, the major tools we have to address the HIV epidemic rely on or are centered within our existing healthcare systems. And unfortunately, these are the same systems which remain relatively inflexible and unfriendly to meeting the needs of complex patients and the target populations that we're talking about. So, for example, in LA County over the last few years, we've spent a lot of energy on day-to-day care activity, so trying to find people who have fallen out of care, engaging them and bringing them back to clinics for care. And I think that one thing we recognized early on was that unless we really changed the way the clinic was structured and staffed, patients would end up falling back out of care. So we really needed to figure out how do we make the care more patient-centered and support the clinics to provide more comprehensive care. And so our approach was to create the medical care coordination model, which we rolled out amongst our 30-plus Ryan White clinics in LA County. And I do want to mention that we created this model of medical care coordination as part of funding that we received through CHRP, the California HIV Research Program. They had a demonstration project to help support the development of patient-centered medical homes for people living with HIV. And so we used that dedicated funding to develop this model. And we implemented it in late 2012, early 2013, and it's been in place. And it's been really effective in improving retention and care and viral suppression. And what medical care coordination, or MCC, is the idea is really investing resources in clinics to hire a comprehensive care team around the provider to really help address complex psychosocial and medical needs of patients. So it includes a nurse case manager, a patient care manager is usually a social worker or equivalent, and then a caseworker. And they really are going through the patient panel and identifying people who are either already experiencing poor health outcomes or are at risk of that. And they do comprehensive assessments, some brief interventions, and really try to provide dedicated energy towards helping these patients stay in care and address their other competing needs. And so that's really been a successful intervention for us. And I think what we're looking forward to in the coming years is how do we build on that infrastructure? What else could we do to help further those teams? Like they've been able to, double the number of people retained in care and virally suppressed, but how can we get to 100%? And I think some of the ideas that we're thinking through include trying to use MCC as a foundation and layer on additional resources. So we've supplemented the teams with patient retention specialists, so somebody who could actually go into the field and try to find patients who are lost to follow-up. The hope is maybe to do something with piloting a substance use counselor in some of these clinics to really see how does that play a part, because we know that there's the teams are identifying people having a lot of SUD and mental health needs, but linking them and actually successfully getting them to get services is a big challenge for us. And so that's sort of the new directions we're going in with the medical care coordination model. The other thing that we're doing within the health department is more case conferencing on some cases of people who are falling through the cracks. I think since we're such a big health department, typically we've not really done that, but that's something that we started as part of the molecular cluster detection activities, and we've now taken it a little bit broader, where we're getting more involved in trying to help troubleshoot patients who are really just, nothing else is really working for them. And I've been recently engaging with more of our providers in the community, and just today I got an email saying that one of the patients that I was working with a provider on, so it was a woman who's in her early 40s, has had HIV for quite a while, will come in for appointments but never taking her medications, is showing up again, basically being hospitalized practically every month because she has very few T cells. But she comes to the clinic, so she really likes the clinic. It's a good place for her, but she just will not take her medications and so the provider was able to get compassionate use for the long-acting injectables approved and gave her the shot today. So that's a success. And we're then able to, And we were working with her, what else could we do? And so we're able to get some financial incentives in place and sort of on a case-by-case basis, trying to see what are those models. We need to give all our resources to these patients and really create unique opportunities to sort of meet their needs. And so I think that's what the future directions are, is we're gonna have to do more of that kind of work. And as I mentioned, I think financial incentives do play a part, and I think in particular for young people living with HIV, I think it's a critical thing to pilot and and with the idea being that young folks are going to lack some of that ability to do planning and stay engaged in care, and that's true. And with all chronic illnesses, young adults have a really hard time staying in medical care, and so I think that we should really center on that group as a first group to try to pilot more financial support for. And then in terms of how could we sort of work more closely together, as Tom and I were talking, I mentioned an example from the STD world where we actually have worked very closely with our regional partners in other jurisdictions, and that involves the very acute problem of congenital syphilis. So unfortunately now it's all across California, but in the first few years, it was just a handful of jurisdictions that were really facing this issue. And it was something that was really new for many of us. Many of us were addressing STDs and syphilis with a primary focus on trying to prevent it largely in MSM populations. But now we're talking about women who are pregnant, have comorbid substance use and mental health issues, homelessness, heavy meth use, and really having to shift gears and figure out what can we do differently. And this was a new problem for us. And so we actually have worked really closely with the state STD control branch, and they brought together jurisdictions in a similar but much smaller type of setting. And then what they did this past year was actually require every jurisdiction to bring a maternal child adolescent health partner to the table. And so I think that there are potential models for us to do that if our federal partners can help us bring other partners to meetings, like force that issue to bring, maybe SAMHSA could force mental health or SUD provider, partners locally to the table to help us talk through these issues. I think that would be a really great partnership. And then lastly, I think there's just some really easy ways we could try to share ideas in a more informal way than having large, big meetings. I mean, these are really great to bring to the surface large issues. But one thing on the STD side we did is the CDC started for congenital syphilis, a base camp, like a SharePoint, where we can basically just share like protocols and procedures. And I think for some, I think there's more opportunities for that. There's also an LA County PEP Prep work group, which there's many active members here. And I think that that's a great opportunity, like virtual work groups for people to share resources. I think there needs to be more of that around different topics, retention and care work group, things like that. So, so I look forward to working with all of you.
Thank you,
Thank
Sonali.
you.